Good morning, ladies and gentlemen, and welcome to our event today. My name is Tracy Dow. I am the manager of the Conflict Medicine Program, and today I am happy to be your Master of Ceremony. President Khouri, distinguished panelists, and esteemed guests, in light of the devastating wars our region has endured, and with the rising toll of injuries, it has become more urgent than ever to equip healthcare professionals with the expertise needed to address war-related trauma. The challenges faced by medical teams in responding to conflict-related injuries highlight a critical gap in preparedness, and this demands immediate attention. Bridging this gap requires context-specific education and training programs designed to specifically equip healthcare professionals with the skill set that is tailored to conflict settings of the MENA region. Today's event aims to initiate a dialogue between experts from the humanitarian, medical, and academic sectors about the need to integrate conflict medicine education into medical curricula, with the hope that this will serve as a foundation for future similar initiatives. Through two moderated panel discussions, we will be exploring two key questions. One, why is conflict medicine important? And two, how can we integrate it into medical curricula? But before we go into the panel discussions, I am honored to invite to the stage President Fadlu Khouri.
Good morning. I think that the room, which is probably could be twice the size, was squeezed, but I never worry about audiences with the Global Health Institute. Always get wonderful people and collaborators. So not long ago, we faced one of the most severe crises, short but severe, in this country's modern history, a period that tested every aspect of the resilience of the people and institutions alike. And make no mistake, that crisis is not over. Amidst the chaos, the American University of Beirut stood at the front lines as best it could, providing care to those wounded not only by physical violence, but increasingly as the attacks went on, providing care for those who had the deeper trauma on one level of displacement and despair. And this is a phenomenon we're seeing across the region, from Gaza to the West Bank, to Syria, to Lebanon. So in these moments, the limits of traditional medical education become strikingly clear. Treating a patient in a conflict-affected area is not the same as treating one in a relatively stable environment, as much stability as the world can see these days. Today, we're confronting the urgent question of how we prepare the medical, nursing, and healthcare workforce to the realities of conflict-affected settings with the skill, knowledge, and adaptability that such work requires. This used to be part of the core curriculum of medical and nursing education during a century of ongoing wars, and particularly in the early 20th century, as war after war after war resulted in what the Brits call the Great War, World War I, and then what some would argue is the Greater War, World War II. And that goes back to the basic principles of medicine and nursing, not just the body, but the mind, the spirit, and in the case of conflict-affected settings, the fractured social fabric of entire communities. The MENA region and the Levant in particular are no stranger to such challenges. Decades of conflict have demonstrated that healthcare systems, as they are ill-prepared to navigate these unthinkable conditions. And that's gotten worse as the chronicity of the wars have taken place and the resources have gotten more and more stretched. So these experiences compel us to ask, are we preparing our future healthcare professionals to be able to operate under such pressures? Are we not the ones who have the responsibility to ensure that these individuals, both here and around the world, are in fact ready to face all odds? As a medical physician, I know that the universal clinical competencies alone, even if they're excellent, are insufficient for situations like this. The realities of conflict develop a deeper, more nuanced, more specialized skill set, one that integrates all dimensions of trauma, biological, psychological, sociological, while also accounting for the unique conditions of fragility, displacement, and recovery. This is precisely the challenge and the opportunity that AUB's Global Health Institute is addressing with its innovative programs. Through its Academy Division and its Conflict Medicine program, GHI has positioned itself as a leader in this critical discourse and action. GHI's Certificate in Conflict Medicine is a testament to the potential of e-learning to transcend barriers of geography and access. And e-learning is something that sadly for the last 6 years, we've had to rely on increasingly and occasionally exclusively. So we better get good at it. The advantages of e-learning are substantial. We can overcome asynchronous modalities, support healthcare practitioners in strengthening their skills, not only in delivering care that's contextualized to the realities of the conflict, but also in conducting research. This research has to be aimed at advancing the science and informing and transforming practices on the ground. Now, last Friday, the President of the United States issued yet more executive orders, including stopping all foreign assistance, or what's called, they call it foreign assistance to every country except Israel and Egypt. This immediately arrested a number of health programs globally, including some of the World Health Organization's programs. And that speaks to some degree to our inability across the globe to make the case about how valuable the work being done is, how irreplaceable that work being done is. And in my opinion, as someone who's done research for most of their career, I'd say most of their life until taking this position, the only way to make that case is to publish research that is invaluable, immutable, and that moves the field. This is what this program is doing. It's integrating conflict medicine into medical education, but also setting the stage for people to do fundamental research. And these are the kinds of programs that remind us that education can do more than inform, it can transform. I also recognize that no single program, institution, or individual could shoulder this responsibility alone or can make this case. Sustainable change requires collaboration on an unprecedented scale. It also mandates diversifying our revenue streams so that the interruption of one revenue stream does not interrupt either the research or the service or the patient care. This gathering today is very timely. It reflects this understanding, bring together academics, healthcare professionals, humanitarian leaders, and students who share a common purpose to integrate conflict medicine into the medical curricula of the MENA region and beyond. Let's not underestimate the significance of this particular moment. The decisions we make here today will not only shape how we educate future physicians, nurses, and healthcare professionals, but also how we define their role in a world where healthcare must often serve as a bridge between survival and stability, between despair and hope. We've seen health systems rally during the pandemic, including the famous NHS in Great Britain, only to return to their pre-pandemic levels. Same in the United States, same here once the crisis has passed. And that indicates that all of those systems, for all their strengths, failed to learn the full lessons of emergencies. It is time to not only learn those lessons, but to integrate them into our daily care. My friend, the renowned plastic and reconstructive surgeon Hassan Abu Sitta, who's treated injured patients in war zones across the region, and who I'm proud to say is the unique combination of an AUB faculty member and the recipient of an honorary doctorate, said during his acceptance speech at our 2024 commencement that 45 years ago, and I quote, the African-American writer and activist Audre Lorde warned us that the master's tools will never dismantle the master's house. This is a critical observation. What it is also is a call for new tools, the refinement of our tools, and progress in these tools on a global level. We need to develop tools, including educational, research, and service tools that are adaptable and that are permanent, not things that we keep in the closet and we bring out when there are attacks or bombs or something else. Dr. Abu Sitta's words remind us that education is not just about responding to challenge. It's about crafting those tools, developing those tools, integrating those tools, and refining those tools. And that really is the core mission of the Global Health Institute at the American University of Beirut. It's to take best practices across the healthcare professions, to do research, to build capacity, and to provide service to as wide an audience as possible under as approachable guidelines as we can put together with consistency, but to make it available to as many people as we can, particularly healthcare providers at every level, initial primary all the way to quaternary care givers at not just affordable costs, but increase that availability. As someone who spent much of my life in both medical practice and education, I'm acutely aware of the fact that when we equip our students, our future doctors, nurses, and technicians, with the tools to meet the demands of fragility and conflict, we empower them to do more than treat wounds. We empower them to rebuild lives, to restore dignity, and reaffirm the essential humanity of medicine, of nursing, of the health professions, of what I would call the healing professions. The American University of Beirut has a long and proud history of serving the region through education, research, and service. Not to our liking, much of that history has been in the midst of conflict. But today we reiterate that commitment, not as an abstract ideal, but as a concrete call to action. Together we can create a future where medical, nursing, and health professional education are not only responsive to the challenges of conflict, but proactive in shaping a more resilient and equitable healthcare system for all. Good luck. Thank you all for being here, for your dedication, and for your shared commitment to this mission. In the 21st century, healthcare must become a right. It needs to stop being a privilege. Thank you.
Thank you, Dr. Khouri. Allow me now to welcome Dr. Shadi Saleh, the founding director of the Global Health Institute.
Good morning, everyone. Sabah al-khair. Thank you all for coming. I am in the unfortunate position as a speaker to speak between Dr. Khouri and Dr. Abu Sitta, but fortunate to, because I'm a lifelong learner on whatever is spoken before me or after me with Ghassan. So I think the president has basically, in all of his speeches, is quite impressive. But when it comes to speaking about healthcare, being an academic and a practitioner for so long, I always feel the depth of the discussion given from practice, education, teaching, learning, and research. So let me tell you, the stage has been set quite well, and then with our exquisite speakers, I'm eager to learn more. But let me tell you from an institutional standpoint where we're coming from. So over the past, since our establishment in 2017 as a Global Health Institute, with the establishment of the conflict medicine program, I think in 2018, it has been quite apparent for us that there's a chasm between what healthcare professionals are learning in their respective schools, medical schools, nursing schools, pharmacies, and what's particularly happening on the ground, specifically in conflict settings, specifically in our region, which is an epicenter of a humanitarian crisis for the past 75 years. We have been told over and over again by experts in the field, by practitioners in the field, Dr. Potokar and others, that the set of skills that is required in these settings is somewhat divorced from what is being taught in traditional medical schools, nursing schools, and healthcare professional schools. And who is better than the American University of Beirut and our partners in this region, starting from Lebanon with our sister organizations, and in the region with others who we are coordinating with in Iraq, Yemen, Syria, and others, to come together, and other regions in the world, to come together and start collectively, but very institutionally and systematically think on how can we integrate perhaps a unique feature of how to practice medicine or how to practice healthcare in these regions into teaching those students on how better to do it from day one, instead of volunteering with the ICRC, with the MSFs of the world, and then learning it 3, 4, 5, 10 years later. So how can they get out of their education knowing how to practice in these settings? And this applies to other parts of the world that have different challenges. So for example, if you're talking about Germany, a population where the elderly proportion of the population is significantly increasing, it's only natural that more focus in medical education be on geriatric care. In our parts of the world, unfortunately, we have more conflicts, and hence we want our people who graduate from these healthcare professional schools to be better equipped upon graduation, not after 5 years, not after 10 years, upon graduation on how to better serve and deal with the emergencies in their own settings. So this is sort of the preamble. We want to do it institutionally, we want to do it collaboratively, and we want to do it in a way that doesn't threaten the traditional medical education or healthcare education, but supplement it in a way that makes sense for our region. So this is the background. We are committed as an institution with the blessings of our leadership, of our president, but also with the commitment from the Global Health Institute to be a facilitator of that discussion, and hopefully at a certain point a facilitator of its actual integration when it comes to medical education. So thank you so much for coming today. I am as eager as you are to learn during the day from our different and wonderful speakers from all over the world, and I look forward to a fruitful discussion that will result hopefully in some practical steps. Thank you. يعطيكم العافية.
We will now be moving to our first panel discussion. We will first start by a keynote speech given by Dr. Ghassan Abu Sitta, the Conflict Medicine Program Director. Dr. Abu Sitta is a plastic and reconstructive surgeon with over 30 years of experience. He has been recently elected as Director of the University of Glasgow in UK. Dr. Abu Sitta has extensive experience on the medical front lines of conflict zones, including Iraq, Lebanon, and Gaza. His expertise lies in war wound management, with his research focusing on the biosocial consequences of war wounds and the relationship between conflict and medicine. Dr. Abu Sitta, the floor is yours.
Thank you very much, and thank you very much, President Khouri and Dr. Saleh. So, a few years back, when the discussions started at the AUB on the need to try to systemize our experience in this institution, in the management of the health consequences of war, and trying to understand how knowledge in medicine is converted from experience to expertise, and then processes are created where it is the institution that becomes the repository of that knowledge and not the individual with whom it disappears when they retire. The Conflict Medicine Program and the Global Health Institute were created exactly as that machine that converts experience into expertise through knowledge creation, knowledge analysis, and then knowledge sharing in ways that improve the ability of health professionals in the region to provide best possible care for their patients. And it is unfortunate that as a result of the fact that this region lies on a geopolitical fault line, that we have known nothing but endemic wars. If we create a timeline from the First World War to yesterday, and we watch how from the First World War to 1948, to the 56 war, to the 67 war, to in the 50s, what happened in the 50s in Lebanon, to the wars in the region, to the Iraq-Iran war, to all of these wars, we realize one critical issue is that conflict-related ill health can constitute an endemic disease in this region. Yet we stand in a place where that is not reflected in the health system and in health education. We still teach medical students about rare syndromes that occur in 1 in 2 million, when we know that in Iraq, on graduation, they'll be in the emergency department, or in Palestine, they will in their lifetime see multiple war wounded. Same in Yemen, same in Libya, same in Syria. And that is the job that we have assigned ourselves. How do we create a process in which the research is converted into teachable knowledge that then gets embedded at formative parts of people's medical education? And that is the critical issue. We have watched numerous organizations have valiant efforts at trying to impart this knowledge far too late downstream, after people's skill set had already been formed and the view of the management has already been turned into concrete. And so courses that are designed for doctors and nurses after they specialize seem to have had limited impact. But we've also witnessed something else that's happening in the opposite direction. The ICRC is one of the world's oldest humanitarian organization, or MSF, or other organizations have found it increasingly difficult to recruit healthcare workers, because that surgeon in the 70s, in the 80s, who was able to do it all, to put the external fixator, to open the abdomen, to do a burr hole, has disappeared. And increasingly, through subspecialization, more and more surgeons are spending less time doing surgery in general and being forced towards a super specialization that makes them very difficult to deploy in austere and resource-limited conditions. And so we at the Global Health Institute and the Conflict Medicine Program have worked in trying to identify ways in which we can alter that equation, based on the principle that if you catch them early, then you're able to mold their views on the management principles. And so the introduction of the Conflict Medicine Certificate was one of these initiatives that we were able to partner with friends in Adan University, in the Islamic University in Gaza before the war, in northern Iraq, to highlight the usefulness of that introduction into undergraduate or into very early postgraduate education. And these courses are not only contextualized in terms of context, but in terms of the delivery mechanism. So in asynchronous e-learning allows those in Gaza and in Yemen and in Iraq to access this knowledge at their own speed and according to the availability of internet connection in their country. And so what we want is to take this a step further and to create mechanisms by which seamlessly this knowledge becomes imparted into nursing students, into medical students, into residents of all specialties. And therein lies the idea of conflict medicine. We have seen in Gaza, which really has been the ultimate war, 15 months of a genocidal war. We have seen how every aspect of the delivery of healthcare becomes conflict medicine. Understanding how to look after dialysis patients in these circumstances, whether it's in Gaza, in Syria, in Libya, or understanding how to screen and treat cancer patients in these conflicts, understanding this ever-present reality of antimicrobial resistant infections that are now present in almost all infected war wounds. All of these are critical components of what we feel we need to be teaching our nurses, our doctors, our health professionals. So early introduction, integration of this disease load. As medical educators, we believe that we teach medical students and nursing students for day one, and then postgraduate training takes over afterwards. But truly, at day one, a medical student in Iraq, or in Libya, or in Palestine, or in Lebanon, or in Syria, or in Yemen, needs, or in Latin America, where weapons wounding is almost like a chronic civil war. All of these students need to understand how to manage these patients, how to keep them alive, and then how to manage them to minimize both mortality, morbidity, and residual disability, but at the same time, minimize the impact that it has on the health economy. And we see it in every war, unfortunately. It is almost like the absence of institutions like the Global Health Institute, which means that experience does not convert into expertise. And therefore, every generation of health professionals learns their war surgery, their conflict medicine in the current war, rather than are taught it by previous generations. And that is the kind of lottery that we want to end. And this day event hopefully will be the starting point. Thank you very much for your time. So our first panel is entitled Contextualizing Medical Education, Why Conflict Medicine Must Be at the Heart of Medical Education in Conflict-Affected Settings. And really, we're extremely fortunate to have a group of speakers and panelists who really constitute what is best in this field. Professor Tom Potokar is the founding director of Interburns and previously the chief surgeon at the ICRC. He was founding director of the only organization that looks at the treatment of burns in low and austere settings, and was a professor of global burns injury at Swansea University. He has really been able to straddle both academia, clinical work, and humanitarian work, and brings with him a wealth of experience in dealing with the issues that we will be discussing. Dr. Tim Goodacre is a consultant plastic surgeon and was the Vice President of the Royal College of Surgeons of England and the President of both the British Association of Plastic and Reconstructive Surgeons and the European Board of Plastic, Reconstructive and Aesthetic Surgery. And I have had the honor of working with Dr. Goodacre both in Gaza, in training programs, and on the boards of multiple organizations where he works. Dr. Abdel Nasser Abu Bakr is the WHO's acting representative in Lebanon, and he'll be joining us online. He is the program area manager for the infectious hazards prevention and preparedness unit in the health emergencies program of the WHO regional office in Cairo, with over 25 years of experience in public health leadership and epidemiology. Dr. Abu Bakr has played a key role in strengthening national emergencies in the region and public health security capacities. And then we have Dr. Muhammad Hayasat, who's a trauma and acute care surgeon at the Jordanian Royal Medical Services, and Dr. Muhammad really brings what we feel we can learn from the Royal Medical Services in terms of maintaining deployment readiness, in terms of integrating medical education and conflict medicine. So if we can invite the panelists to join me. So we thought we'd do this in terms of themes. And so the first theme that I'd like to start discussing is in terms of the most recent wars in Lebanon and in the Arab world. Do you believe, Tom, that medical students, and you particularly in this war in Gaza, where medical students have needed to become a resource, do you feel that medical students were properly equipped and are properly equipped to address the unique challenges that were posed by this conflict?
Thank you, Hassan. Well, a very simple answer would be no, but I feel that clearly needs some explanation behind it. And I think the introductory talks that we've heard have really brought all this to the forefront. So thank you very much for asking me here and to comment on this. I think, first of all, we need to examine what are the specific challenges. So are medical students adequately prepared to deal with the challenges? What are those challenges? Well, I think in modern conflict, you know, the biggest challenge as a group, it's high energy transfer. I'm going to be talking about the surgical side, obviously not medical problems. Is high energy transfer wounds, which are very different from civilian wounds. We also know statistically that the majority of injuries are going to be survivable injuries, are going to be limb injuries. So somewhere around 80% of survivable injuries will be limb injuries. And this means extensive soft tissue damage, open fractures, burns, etc. Now, the majority of those need to be dealt with what is called an orthoplastic approach. And in many countries, even the concept of orthoplastic isn't really understood. So I think there's a lot of clinical decision making and clinical experience that isn't taught. And then, of course, we also have on top of that the need to address some of the non-clinical, which I think is also extremely important, and whether that's aspects around, for example, international humanitarian law, but also the pathophysiology of some of these injuries, etc. So I think there's a lot that needs to be learned, but we also have to look from the other side, the question, why address this to medical students, which I think is so important, because with medical students, as you've said, you can start early and medical students can learn. The problem when you're teaching this, as you alluded to earlier, to those that are already qualified or have been qualified for some time, they have a double process. First, they have to unlearn what they've learned, and then they have to learn new stuff. And if we look at how that works in terms of what's referred to as the knowledge to action process, so in other words, how you get knowledge and how you then turn it into behavior, etc., it's actually very difficult once people have habits to change those habits. So I think it's critical that medical students are taught the basics. Now, we cannot start teaching medical students highly complex surgery. That's not the point. But there are some very simple, basic things that should be started very, very early, and that means that then later on in their careers, they don't have to unlearn stuff. And that is, I think, something that's really, really important. And so there are huge challenges, and at the moment, we are sending medical students out, as you've mentioned, that have been trained in certain topics and things that they will never see in their life, and yet we're not covering something that is, as you've mentioned, is endemic here. So I think there are a lot of challenges, and it is absolutely the time to address these.
Thank you. So, Tim, as someone who has worked in medical education both in the UK and in Gaza, What do you think are the main barriers for that kind of knowledge creation and knowledge transfer?
Yeah, thank you, Hassan. Thank you very much for inviting me to participate in this important topic. The first thing, I think, just to sort of set the scene, I think just having witnessed the conflict in Gaza in the last year, it would be hard to imagine that one could adequately prepare any medical student for the scenario which they've been thrown into. I think we have to be, in a sense, realistic about what preparation can be and can be given. And my heart goes out actually to many of the students who I came across who were displaced from their medical schools, and were immediately thrown into desperately difficult scenarios to manage, which challenge all of us, let alone students, and so preparing them is very difficult. The second thing I'd like to say is that we have had, you talked about, two of you, the President, and you also mentioned e-learning in your preamble talks. Absolutely vital component of extending knowledge across boundaries. You talked about non-contemporaneous time, so you can do it in your own learning. Very, very important, but we have to recognize that there will be limits. There are always limits to what we can do digitally and without face-to-face, without the true interaction of learning on the ground and the face. So in some means of extending we have to bridge that gap between what we can learn theoretically and what can only be learned face to face, at the bedside, in the emergency room, in the crisis situation of the operating room, and so forth. I think you asked me what are the obstructions, and the sad reality is that almost all the standard-setting organisations in the world, in the UK, those are the Royal Colleges which set standards. In the American situation, it's the American College of Surgeons and so forth, or the American boards. There's the Arab boards. We have the European Board of Plastic Surgery. Almost all of those organisations, the variables are set in peacetime, with the sort of scenarios which we encounter in the most developed health systems of luxury systems, and not in these circumstances. So the standards which are set are inevitably set by those people, and we drive our teaching that way because everybody wants to meet the standards. They want the ticket to be allowed to do what to practice and so forth. So we have a problem there. My final comment I want to just mention, and I'd like us to, I hope you'll be able to discuss this, is the role of simulation. I think we are only beginning to embrace the huge potential for proper simulation in teaching. It's growing rapidly, but I think the boundaries with AI in particular have yet to be reached. We're just at the early stages, the baby steps of simulation teaching. And I would imagine if you can picture some of the scenarios that you've seen here, where you suddenly have mass casualty situations, maybe we could simulate that much more actively. We can take film from real life episodes and dissect it and use it as teaching material. So I think we need to talk about where simulation goes and how we can invest in that in the future.
Thank you. So I'll move to Dr. Abu Bakr with the question, as someone who has been in the position to, and with the unenviable job of trying to prepare this region for the kind of emergencies that we have been highlighting are absent from medical and nursing curricula. Where do you see, in terms of that implementation, the missing skill sets that exist amongst the workforces that you try to mobilize for these emergencies?
Well, good morning, and thank you very much, Dr. Absita. And I just want to thank for the organizers, the Professor Hori, as well as Dr. Shadi for organizing this very important. I think the question is very important, and I think the topic that we're discussing is more relevant today than any other time, especially now coming out of the crisis that we have seen in Lebanon, but also in Gaza, which is still ongoing. Also, there's a ceasefire. We have all seen that the impact this conflict and crisis might have in human lives, but also in the economy and society in general. Now, in order for us to minimize the impact of those crises and allow me to not to strictly on conflict, but rather on emergencies, because we do have other natural disasters and also other man-made disasters, which also requires the intervention of the medical community to deal with. As you know that in this region, and I think our previous speakers have mentioned that in MENA region actually deals with the almost 64% of the crisis in the world. And I think what we have seen is half of the MENA country regions are currently experiencing, whether it's acute or protracted complex emergency, whether it's a conflict, flood, and anything else. What we have seen right now also is almost 70% of disease outbreaks and epidemics actually occurs in conflict-affected countries, which means that since this region is experiencing the largest conflict and natural disasters, we also actually burdening most of the outbreaks. On the other important element is, which is relevant for the preparedness and response, is health indicators. If you look on the key health indicators in this region, we have the worst health indicators. And for sure that many of the countries in this region will not meet the SDGs. Now, I'm just trying to put the layout of the context. Now, the question is, how can we overcome and how do we need to deal this? And I think my colleagues, previous speakers have mentioned that. We rely mostly as a WHO on the healthcare where there are doctors, the nurses, and other skills and practice need to overcome and also to assist. And I think we have a very practical experience in Lebanon for September this year, what happened and how we as the healthcare community, the government, the Minister of Health, others, how we dealt with and what we have done. I think now, it's not only it's important for us to integrate, the knowledge and skills that we, the medical students and nurses need actually, but they do have an opportunity that many of us didn't have during our training time. As the previous colleagues have mentioned that the technology has improved, the skills requires to deal this has improved, and nowadays actually things can be resolved even through online. And I think it's not only the basic training, but also what WHO advocates often as part of the preparedness and response is continuing and regular refresher training. The reason why being is that because the techniques, the practical skills that we need to deal with the wounded patients in the conflict is changing. But at the same time, also the type of weapons that's being used have changed over time. And I think also the skills that we need to adjust. And I think we have seen recently in Gaza, and also in Lebanon, most of the different type of weapons that have been used and impact that it may have. And I think the classical example is during the September 17, during the Beirut explosions. That was a very unique experience for all of us. And I think both the academic institutions, the WHO, as well as other colleagues have struggled. How are we going to deal with this new phenomenon, new injuries that we have not seen before? And I think having the opportunity to integrate some of those lessons learned for recent crises, whether it's in Lebanon, Gaza, Syria, Yemen, Sudan, on the education and the academic institutions, it's very helpful. And what I would like to summarize my point is that if we are better prepared for all of us, I think one, we can minimize the impact. And I think we have seen in Lebanon for this recent crisis, because of the investment that the Minister of Health, the government, the other institutions have made on the preparedness and response, I think we have saved many, many lives, especially the first few weeks of the conflict, because we have invested a lot to the hospitals for being readiness, but also the healthcare workers that we have trained, over 6,000 healthcare workers for the new skills that they have need. And that helped us to save many lives. So now we have a more practical examples. And I think I have to thank also Dr. Abusita and his team and other emergency medical teams that have been deployed to Lebanon. And the reason why we deployed is because in Middle East and MENA, we don't have that capacity. We have very few capacity, and that's why we bring outside. And I think building our own capacity to deal with emergency, increasing the knowledge and skills is very critical. And I think at the end of the day, if we invest the knowledge and skills about the trained doctors and nurses, as well as those who have already been trained, with the new technology, with the new skills, I think we will be able to save more lives. Thank you very much.
Thank you. So I'd like to move to Dr. Muhammad. And Dr. Muhammad, I think the humanitarian sector and the civilian sector that's now in the new wars, dealing with the majority of the wounded, have a lot to learn from the medical services within armed forces. And with Jordan's Royal Medical Services being the oldest medical army corps in the region, my question to you is really twofold. What are the issues that you deal with in receiving recent graduates from medical schools and turning them into deployment-ready health professionals? And how do you maintain their skill sets in between deployments? And so that continuous readiness in between deployments is critical. And what is your view as someone who's an educator of people that need to be deployment ready? Are the knowledge and skills gaps that you feel can be given to them while they're in medical school that make your job easier?
Thank you, sir, for your nice introduction. I'm very happy and excited to be here with you all, the pioneers of the conflict medicine, talking about these hot topics and trying to show the importance of the conflict medicine. At first, I would to explain that trauma system is have four main corners. First, it's an injury prevention and preparedness phase. Second, it's a pre-hospital phase. Third, it's a hospital and definitive phase. Fourth is a rehabilitation. And we have to improve all of these parts to get a better outcome. The medical teams and trauma surgeon, it's a vital structure of the trauma system. So the Army prepared its medical teams, especially trauma and acute care surgeons, for emergency response in conflict setting through a combination of specialized training, simulated exercise, and operational experience. We train them first by pre-deployment training and education. Surgeon and medical staff receive intensive training in combat medicine, focusing on life-saving interventions such as advanced trauma life care, saving, hemorrhage control, airway management, and damage control surgery. So in GRMS, we adopt multiple courses verified by American College of Surgeons, like pre-hospital trauma life support, advanced trauma life support courses, and other courses like search and rescue courses, TCCC, technical combat casualty cares, and dealing with casualty result from chemical burn, radiological, nuclear events, even disaster and mass casualty management courses. Plus, we have a simulation and simulation labs. Also, we trained our team by field exercise and joint operations, like mass casualty drills, field surgical skills. Medical teams practice setting up and operating in mobile surgical unit, forward the surgical teams, role 2, role 3 medical facilities. This includes learning how to work with limited resources, such as during field surgeries and field surgery or in austere environment. We also train them to use a medical evacuation procedure, either ground evacuation or air evacuation and its need. Second, we trained our members, medical teams, and surgeons by continuous professional development and real world experience. Surgeon and other medical staff gain hands-on experience in real-world combat setting, learning to adapt and make a decision in unpredictable and often austere environment like Gaza war and Beirut seaport explosion, Turkey earthquake. After deployment, medical teams are debriefed and receive feedback on their performance, helping to refine technique, and procedures. And add collaboration with allied forces make chance to adapting best practice from various forces in international operation. Third, we train them to use a technology like a telemedicine and remote support and equipment. Surgeon and medical teams have to use a wide range of field medicine equipment such as a portable ultrasound, field surgical tools, and advanced trauma kits to provide the best possible care in the field. Finally, we prepare them to by mental and psychological resilience to adaptation high pressure environment through psychological support, stress management, and well-being. In addition to field medicine, there's also focus on maintaining mental health and preventing burnout, both for the medical teams and for the patient they care for. Overall, the Army medical teams are extensively trained to respond effectively and efficiently to trauma in combat environment, ensuring that personnel are receiving the best care possible in life-threatening situation. Over, sir.
Thank you very much. So my next question, I'd like to kind of ask all the panelists. One of the projects that we're working on at the Global Health Institute and the Conflict Medicine Program is to try to understand what it would look like to create a set of skills and knowledge indicators that would eventually move towards an accreditation process, so that people who work in the civilian setting can become accredited to become deployment ready, and whether you believe that that is one of the ways that we are heading towards in terms of helping organizations identify those with the right kind of skill set, and whether that then becomes in itself a core curriculum for conflict medicine, even within countries where this kind of knowledge needs to be enshrined.
Yes, I think it is. There's been a lot of talk about training, and I think training is clearly a critical step, because people need to have the knowledge. But when we look what actually happens on the ground, it's not what you know, it's what you do. And there's a big gap between what people know and what they do. And I think you alluded, Ghassan, in your initial introduction. If we're honest, let's face it, there have been numerous organizations, academic universities, etc., training that have provided training over many, many years in war surgery, not in the ideal way, I agree, starting too late. And has this really led to that much impact? And I would like to give one example which does relate to this. And I was part of running a training seminar on war surgery in Syria some years ago. And one of the commonest errors that we all know very well in war surgery is closing of wounds primarily, rather than leaving them open and closing them later, which has been learnt many, many years ago and has to be relearnt at every conflict. And how do you address that? That's a big issue. So we trained people, and at the end of this program, they were mostly senior residents in surgery, And I asked them the question, just as if I could ask you here, a similar question. I said, okay, do you all understand the importance of leaving weapon wounds open to prevent infection, etc.? Put your hand up. 100% put their hand up. So you think, great. It's the next question that's the important one. So how many of you are going to do that when you go back to your hospital? Less than half put their hand up. And that's the critical bit, because then it's asking them, okay, why not? You know that's the right thing to do, so why aren't you going to do it? You have the knowledge, why aren't you going to translate that into action? And that's where all the interesting things come up. Oh, my boss says I have to close it. I haven't got time to go back to theatre 3 days later for a second case. The nurses don't like the wounds being left open. The patient wants the wound closed. We don't have enough dressings. Those are the real practical issues. So I think, coming to your point about the accreditation, yes, I do think we need to teach the skills, absolutely, at a much earlier level. And I think having the sort of, there's different levels. You know, there's a basic skill set, and then the more complex ones. And, you know, we talk a lot about general, you know, surgery in general in war surgery, and the ability to do a bit of everything, and that those surgeons have kind of now passed. There's very few left. I think that's something we just have to accept. But also, I would challenge people, you know, when we talk about cancer surgery, you know, we don't have general cancer surgeons that remove a breast cancer and a urological cancer and a brain tumor. We have specialists. And when it comes to conflict surgery, you know, the biggest chunk of the problem is musculoskeletal and bone, so orthoplastic. So I think we do need to absolutely train and see the competencies, you know, in that specialty particularly, and that's not in the realm of generalists, you know. As I say, we wouldn't do that for other things. Why should we be doing that for war surgery? And war surgery is always treated a little bit as, you know, yes, you have your normal civilian surgery, and then, well, that's a bit that, you know, yes, we'll take people that don't really know, and you know, they'll probably be okay. So I think it's critical that we do develop and have competencies, but we look beyond just training, if you like, so beyond the knowledge to look at, okay, what are also the barriers to implementing? So you may have the right competencies, do you also have the opportunity and the motivation to be able to act on those?
Tim, and particularly in terms of the growth of courses within the Royal College of Surgeons in dealing with specific skill sets, how do you see the role of organizations like the Royal Colleges that create standards and curricula and accreditation in developing such a program?
I think we probably can overstate the role of the colleges themselves. I think we perhaps have to, we do have to drive an understanding that the conflict surgery and conflict medicine and conflict management generally ought to be integrated into general competencies, particularly for surgeons. But I'd like, if I may, just to go, let's comment right back at the beginning of the curriculum. One of the problems we have in healthcare with training doctors is that the knowledge tree that people need to know has grown immensely in my lifetime, in decades. There's so much more that we need to encompass now. That's been what's happened in my medical school, a prestigious medical school in Oxford, is that the amount of time that students are exposed to surgery has halved in my lifetime. Now, not only has it halved, but a lot of that exposure that they have is to minimally invasive laparoscopic surgery, and they rarely ever see open wounds. There's also been an expansion in the number of medical students and a commensurate lack of exposure to the open wound management. And we've devolved a lot of wound management into tissue healing nurses and the nursing side, haven't we? We've all seen that grow very, very admirably. But what has happened is we have lost the centrality of managing wounds and the wounded body in medical education generally. There's been a diminution in that. Now, how do we tackle that? We're probably not, we still need to have, as you say, separate cancer specialists. We are going to need people who are very, very adept at managing biologic management of disease and so forth. So we perhaps have to look more radically at medical education and the standards that are set and what we examine and what we drive people towards in competency. So I do think, in the end, my final comment about our preparedness. At the moment in the UK, I would imagine one of those 1,000-pound bombs that go off in Gaza, that are dropped by the F-16s, would deluge our burn capacity in the UK. I think, Tom, we were at a meeting recently when we were looking at emergency preparedness in the UK, and and they're having them day in, day out, all the time. So the ability for us to cope and to understand is very limited, and we certainly do have to get back into the collegiate structure and into the GMC, the medical curricula, and insist that there are routes through into standards to be set for conflict and wound-related medicine.
Thank you. Dr. Abu Bakr, where do you see, particularly in this conflict where the WHO became the kind of conduit with which emergency medical teams were going into Gaza, where do you see the role of organizations like the WHO are in setting minimum acceptable standards for skills and knowledge for emergency medical teams to have before they're allowed to go into these emergencies, keeping in mind not just the Gaza war, but even less successful experiences in the humanitarian sector, such as the Haiti earthquake?
Sorry, I was muted. I apologize that. Thank you very much, Dr. Abu Sita. I think, as you rightly said, all of us, whether it's a WHO or any other organization, actually requires to be better prepared before the event takes place, whether it's a war, a disease outbreak, earthquake, and anything else. And I think, as colleagues have said earlier, actually, is, of course, developing a very good curriculum, it's very important. But what's more important is that how we can adjust those knowledge and skills that we need even after the graduation. And what's more important also is the deployment. I think one of our speakers have mentioned into that, how we can motivate, the trained, medical and nurses and other cadres to be deployed. And I think that's the most critical things. As a WHO, what we've been working with the health authorities and other institutions is what can we do better pre-crisis? How can we better prepare ourselves pre-crisis? What are the skills? What are the things that we really need? Of course, I will not get into the, I'm not a surgeon and I'm not a specialist on any of these. I'm a more public health and emergency. And I think the area that I care more is actually what happened before and during and after. And I think this is very critical and this is very important. And I think this is what WHO is trying to work with the health authorities and other organizations. And allow me to say that, for example, of course, my colleagues have said that, of course, basic and advanced trauma care, basic surgical skills, all of things are very important. But what's more important actually is the leadership in emergency. It's very important because the people who's going to manage this emergency are same as the medical doctors and other public health officers. And they need to have the leadership to manage these major emergencies that we have into that and how to deal with it. Another important element is how to manage and coordinate large-scale, emergencies like the one you mentioned in Haiti, which was unexpected crisis out of nowhere, in cholera. Same thing in Yemen, the cholera that we have, the worst cholera outbreak in the world for the last 3 or 4 centuries. I think what we really need is healthcare workforce that have the ability and skills to manage and to lead some of those major, crises like what we have seen in COVID pandemics. Another important element is that, of course, we do understand the mental crisis during the war and other emergencies. Also, the healthcare workforce need to have the ability and have the knowledge, skills, and how to help. For example, in the context of Gaza, in the context of Lebanon, I think there are 20,000 people wounded actually, and also 5,000 people died. But hundreds and thousands other people have been impacted through mental crisis. And this will stay not only short term, but even the long term. And how are we going to help? And I think it's some of those skills. That's how WHO actually is working with the emergency medical teams, not only for the surgical, but not only for the burn, but also in the long term, how are we going to help the countries to overcome into that? Another important point that WHO is helping is how we can better plan logistics and supplies. And I have a very good example of that in Lebanon. And I'm sorry to take this example is in Lebanon because this is most recent and our mind is fresh. When the crisis started in September 17, we realized actually the quantity of anesthesia medications available in the country actually is enough only for 1 month. Same thing with the fixatories and same thing with other supplies. And that actually was a wake-up call for us to be better prepared early so we can reposition some of those critical supplies that will help us to save lives. So WHO actually, one of our mandates is to work with the countries, health authorities, organizations, and engage the other experts around the world, how we can better prepare, but also how we can better respond, so at least we can minimize the impact, the healthy consequences, and also the society in general. And that's why I would like to reiterate that as much as I am fully supported integrating education into the academics, but also following up regularly, as part of the preparedness. So at least we can train other healthcare workers and how to manage, how to lead, and how to respond on this. Thank you.
Thank you very much. So, Dr. Muhammad, the Jordanian Royal Medical Services provides residency training across multiple specialties. My question to you is there a unified set of skills and knowledge that you insist that all of the specialties, or at least that those surgical specialties have a set of skills, course set of skills, and those within the internal medicine specialties have a set of skills that all of your trainees have to have? Or do you leave it up to different programs to reflect the ethos of conflict medicine within their training so that to achieve what you eventually want them to be ready for?
Hi again, sir. I just will talk about the surgical subspecialty because this is my point of interest. Our surgical residents have to do a basic surgical skill and ATLS course before he get a senior in residency. We push them to do these courses before become senior and can have a leading trauma team in the emergency rooms. We have a multi, like I said before, we have a multi courses that we adapted and maintain in our GRMS. But this is the gap, we are just started in 2022 about acute care surgery subspecialty because we noticed the gap that you mentioned before, that our surgeon had to become a single organ surgeon. We have a many liver surgeon, we have a many stomach, colon surgeon, but we don't have the multi surgeon that can doing a life-threatening procedures. So we create a trauma acute care surgeon in 2022, and we start from this point. To understand the life, we had to understand the death. The death in the point of injury, it's a two type. It's a reversible death and irreversible death. Irreversible death, it's 80% is about traumatic brain injury, massive traumatic brain injury, or massive major vascular injuries. And this is irreversible death. Just we can do it at injury prevention methods like helmet, wear body armors, and some instructor to prevent the injury before. The second part of death, it's a reversible injury, and it's 83% from hemorrhage. So we are concentrated to stop the bleeding, control the hemorrhage procedure on the point of injuries.
Thank you. So I think we'll open the floor to questions and answers, and we will take someone from the back.
Thank you very much. My name is Mirna Dumit, and I'm a nurse. Thank you for this very important and timely topic. But for me, while reading this title, it looks very sectoral. Why? Because you cannot have conflict, you call it conflict or emergency preparedness, without talking about nurses. Unless you all believe that in our curricula as nurses, we do tackle this topic, and yes, we do, because this is part of accreditation. And we prepare our undergraduate and graduate students to deal in emergency settings or to have emergency preparedness skills. And the core idea in conflict is interprofessional collaboration. And this is what needs to be emphasized. So instead of walking the talk, we need to talk the walk. Reality, you cannot have any conflict resolution in any crisis situation without nurses, because nurses are the heartbeat of every healthcare system. So I would have loved to see nurses, deans sitting, especially in the second round, on the table discussing the curricula. And I would have loved to see, instead of medicine, healthcare. Thank you.
Thank you.
Can I say I absolutely agree with all you said, and the classic example of that in my experience is in East Congo, East DRC, where in many of the crisis situations there, with all the conflict that's gone on, many of the doctors have disappeared, the few doctors there were, and most of the healthcare is being managed by nursing staff who have been upskilled and graded. So yeah, I couldn't agree more. It should be more intersectoral. I don't know, Tom, you've probably got comments.
No, I mean, yes, I agree, and obviously it's multidisciplinary. But I also think, we need to look. It's you're absolutely right. It's nursing, but it's also pharmacy. It's also administration. It's also finance. It's also rehabilitation. There's lots and lots of groups, and clearly, not everybody can be represented all the time. But I think that the clear point is that we focused a little bit on staff here, and if we think of systems building, we need to think it's the staff, yes, but it's also the stuff. You have to have the resources. If you don't have that, you can't do anything. You have to have the space, and you have to have the systems. And that if we want to address and to improve the management of weapon wounded, and also, yes, we haven't really touched on all the medical issues in conflict and the psychological, but we're focusing here at this session on the surgical. It needs to be a systems approach, and we know what the building blocks are for systems. It is, yes, the service delivery, it's the workforce, and the workforce is absolutely, it's surgeons, anaesthetists, nurses, therapists, pharmacists, it's all those people. It's the health information systems. It's the essential medications, the essential surgical kit. It's the finances, and as was pointed out very importantly, it's the leadership and governance. And, healthcare in weapon wounded is it's in series, it's not in parallel. So if there's any gap in any of those, from the point of injury to discharge and reintegration, you can have the best surgery in the world. If you haven't got the rehab, you're not going to get the best results. You can have the most skilled people. If you don't have the resources, you're not going to get the result. So it has to be a system-wide approach, which clearly clearly, yes, involves the whole clinical team, but also a lot more than the clinical team.
Good morning, and thank you very much for all the speakers and for the organization. Very important. And I'd like to thank Dr. Shadi Saleh for really taking the initiative to really focus on conflict medicine. And as the title mentions, it's conflict medicine as a new look or a new vision or an improved vision. Actually, I was, when I raised my hand, I wanted really to take the issue to really bring up the issue of the nurses. But of course, Mirna Doumet, being a nurse, but I would have liked to do it as a doctor rather than a nurse to really highlight the role, the important role of the nurses. Now, having said so, with all the thanks, I addressed myself to Shadi. I think, Shadi, this is really an eye-opener, really, the idea. If I were to suggest something, is really to focus this more on how do we really involve other specialties, like the nurses, like the administrator, like the supply managers. And this is something that really could be a major development in medical education, particularly that the deans are coming in the next session. Also, I would have liked to really involve more the WHO, and not merely the WHO, but also the associations such as the Médecins Sans Frontières and others similar who have had a lot of experience. Of course, your experience is very well noted, Dr. Abu Sitta. This is a breakthrough in, I think, medical education. I think the Global Health Institute could take the lead along with others to really focus it more and develop it into, as you mentioned, developing maybe accreditation standards. Thank you.
Dr. Dina, just because another failing has been to not highlight training in mental health, so it's critical
Yes,
that we hear from mental health.
You heard a piece of my mind about that too. So thank you for this very eye-opening and very important discussion. And I'm very glad to see that we are beginning to move in this direction of more contextual sciences, where we're beginning to look at training programs that actually reflect the needs on the ground rather than dictations from the powers that be. So I do want to highlight two issues. One of them piggies back on the systems issue that Dr. Potokar was mentioning, that also transcends just what happens during the conflict, but also before. So some of the issues that I didn't hear much reference to in the period pre to the conflict in training and education are the systems pressures to, you mentioned, Dr. Goodker, about the diffusion of the roles and the different multidisciplinary responsibilities in caring for a particular patient, which is yes an issue in and of itself, and it's also a result of this shift in healthcare to see more people, to really, in many ways, unfortunately, compromise quality for quantity. So I would like to hear your thoughts about the systems issues that get in the way of training, that may get in the way of these very important changes that we're advocating for. The other issue is mental health, of course. So I think Dr. Muhammad was the only one who alluded to that issue in the training. Because I think that a few very key things to remember. Yes, you need good surgeons, you need good nurses who know what they're doing. And they also need to be able to operate under those conditions. So they need to be able to regulate, to keep their head together under pressure. And with the recent conflicts, unfortunately, we're beginning to see not only new types of weapons, but also new types of threats to the direct safety of physicians, of hospitals. We're seeing hospitals directly targeted, which is really a new phenomenon. So this is impacting the healthcare's ability, the healthcare providers' ability to do their job, because they are now worried about their own personal safety. Also, they share the same traumatic reality as the people that they are serving, not just in person, but also they worry about their families, they worry about their loved ones. How are they going? I think a key skill set that we also need to include in our training is how to help our healthcare force be psychologically strong so that they can endure these unspeakable threats that are being impacted, and so that the effectiveness of their work doesn't get compromised when they have to worry about all these other things as they are attending to their wounded. So I would also like to hear your thoughts and suggestions about those. Thank you.
So, would you, Dr. Bakr and Dr. Muhammad, like to answer that?
Well, thank you very much. Yes, I think I agree with all the points that you have mentioned. I think it is very critical for system building and the preparedness. And in general, I think what we have seen in all complex emergencies, whether it's in Gaza or Lebanon and or everywhere actually, is the health system is the one who feels the burden the first. Whether it's the hospitals, the primary healthcare facilities, and the healthcare workers. And I think unless we better prepared for the health system in general, actually, the health system might fail or might collapse in general. And I think we have seen many countries where they have experience into that. And I think in order for us to overcome some of those challenges and some of those unforeseeable consequences, I think it's the investment that we made, how we can strengthen the system that we have in advance. And I think in Lebanon context, as the country has been experiencing crisis since 2019, I think the resilience of the system, but also the investments being made actually have helped the system to stand with even the worst crisis that we have experienced for the last few months, of 2024. But what's more important actually is it's not only the system is strengthening and how we can prepare itself, but also the collaboration and that we have for all the sectors that we have, because it's not only health sector per se to deal some of those challenges, but also what the role can play other sectors and how they can contribute. And one example I have is when this crisis started, WHO and the Minister of Health, we start collaborating and seeing how we can work together with the syndicates and the associations, which plays a very important role into this. And I think this is what helped us to overcome, addressing even the needs our previous colleagues have mentioned about the nursing, the doctors, the other cadres that we have into that. I think unless we have a close collaboration with all players and all involved entities, it will be very difficult for us to maintain a very strong, resilient health system that can withstand with the crisis that we have seen into that. Thank you.
Yes, hi again. Sir, at first I would talk about nurses issue and other stuff. We know in our Jordan Real Medical Service is a trauma, not a one-man show. It's a team work. So we are dealing with all the member of trauma team, from a surgeon and emergency room doctor, intensive care, and the paramedics, the ICU nurses. We are dealing with all the members of the trauma team. So we have a special courses for our nursing, respiratory course, advanced nursing, trauma life support, ATCN courses. So we understand that trauma, it's not one-man work, it's a teamwork. For the second question, I mentioned in my presentation that mental health of trauma team member, it's a very important issue, because if we don't have a 100% a good trauma team members and mentally well team, they will not give the proper effort, and they will not dealing with trauma patient probably in proper situation. Thank you, and over.
Well, thank you very much. We'll draw this session to a close with this idea that when Israel wanted to destroy the Palestinian health system, it killed 1,000 doctors, nurses, medical technicians, physiotherapists, health administrators, because it understood what we have been, and what many of you have spoken about, is that actually it's a system, and dismantling it means that you need to dismantle all of the components of the system, and strengthening it means that you need to strengthen all of the components of the system. Thank you very much, and I think we're going to take a break now. Thank you very much, and for people to come back in 20 minutes.
Thank you all for joining again. We will now be starting with the second panel discussion. It will be moderated by Dr. Kamal Badr. Dr. Kamal Badr is a professor of medicine specializing in nephrology and hypertension. He serves as a deputy vice president for medical affairs and vice dean at the American University of Beirut. He is the founding director of the Vascular Medicine program at AUB and is an adjunct professor of medicine at Johns Hopkins University. Dr. Badr has been elected to several organizations, including the American Society for Clinical Investigation, the Association of American Physicians, the Lebanese Academy of Science, and the Royal College of Physicians. Dr. Badr, the floor is yours.
Thank you. I just want to sort of make a few introductory remarks before we turn over. I introduce the panelists. I think the first session really posed the problem. We now know what the onus is, and this session hopefully will focus on how are we actually going to integrate this into quote-unquote medical education. Now, to preempt the nursing issue, let me say that my wife is a nurse, and so as much as this meeting is a wake-up call, that's what I wake up to every day. And I would be amiss not to recognize that. And so I want to assure you that it had nothing to do with the program. But I think we have to start somewhere, and I think the Global Health Institute has done a great favor by at least starting to focus a little bit on the medical curriculum, because that's what is going to be one of the core parts of this unit that has been described to be as comprehensive as it is. I hope that from this session, Ghassan, we will come up with some practical answers to two questions. First of all, if we want to introduce conflict medicine into medical education, at which stage should we introduce it? Is it going to be, should it be at the medical student phase, at the resident phase, or should there be fellowships that are designed for that? The orthoplastic skills that were brought up in the first session sounds like an interesting title for a new fellowship. In addition, is this part of medical education as essential to the formation of a physician as knowing about the liver, for example? And therefore, should we have all medical students be involved in it, or should this be a track for a select group of students and residents to get into it? The idea of building a cadre of people who can then be deployed and be effective in that field. So I think I'm going to ask our panelists who have extensive experience both in undergraduate education in the medical sense, that is in medical students, as well as in graduate medical education, as well as in fieldwork, to comment on these. So let me briefly introduce our panel. I'll start with Salah, who's sitting next to me. Salah Zainuddin is Associate Professor of Clinical Medicine and the Associate Vice President for Clinical Affairs so CMO, in other words, and a designated institutional officer and chief medical officer at the Faculty of Medicine at the American University of Beirut. He is an expert in pulmonary and critical care medicine. He oversees 50 residency and fellowship programs, ensuring alignment with international accreditation standards. He is recognized for his dedication to medical education and patient-centered care. Dr. Zainuddin received the Gold Humanism Honor Society Award in 2024. I have known Salah since he was a chief resident, and I can attest to the fact that his engagement in education is not only in terms of assuring its quality, but that his humanism and his care and compassion is what really drives his excellence. Dr. Sola Bahous. Sola, are you with us? Sola is the Dean of the Faculty of Medicine at the Gilbert and Rosemary Shahouri School of Medicine at the Lebanese American University. I had the honor of bringing Sola into LAU Medical School when I was the founding dean of that school back in 2007, and I'm just delighted to see that she has taken the helm for leadership. Of course, being a nephrologist, it qualifies her to do that. She serves as a member of the International Advisory Committee on Artificial Intelligence, is the deputy chair of the International Society of Nephrology Education Program, and is a pioneer in medical curriculum development and innovation. She played a key role in launching our groundbreaking engineering pre-med program at LAU. Our next participant is Dr. Abdel Hakim At-Tamimi, whom we are delighted to host from Yemen. He is the Dean of the Faculty of Medicine of the University of Aden in Yemen. Dr. Tamimi is Professor of General and Laparoscopic Surgery and Trauma Surgery, as well as the Dean of the Faculty of Medicine and Health Sciences at the University of Aden in Yemen. He serves as a member of the Scientific Committee of the Arab Board of Surgery and leads the Yemeni Surgeons Association. Dr. Tamimi is recognized for his contributions to surgical education and the development of healthcare systems in Yemen. And we are particularly pleased because Dr. Tamimi is one of those people who have piloted in the University of Aden the certificate in conflict medicine of the Global Health Institute, launched 4 years ago, and we are looking forward to him sharing with us that, as well as other contributions in the field. And last of my no means least is my friend and longtime colleague, whom I have the honor of introducing as the Dean of the Faculty of Medicine at University of Balamand. Sami Azar is a recognized authority in the field of endocrinology, particularly in diabetes. He serves as the Vice President for Medical Affairs and Dean of the Faculty of Medicine at the University of Balamand. He previously led the endocrinology division and the diabetes program at AUB and serves as an instructor in medicine at Boston University School of Medicine. He's board certified with the American Board of Internal Medicine, Endocrinology, Diabetes, Metabolism, and past president of the Lebanese Society of Endocrinology, Diabetes, Lipids, and has authored over 250 peer-reviewed publications. So he, as I mentioned, has established himself as a true leader in the field. So, with the idea that we want to answer these two questions in terms of where in the medical curriculum we want to fit conflict medicine education, let me start with you, Salah. Salah, you've had tremendously long experience in graduate medical education. You lead that at AUB. And so from that perspective, do you see the possibility of formal residency and or fellowship programs in conflict medicine? What do you see are the obstacles towards achieving that, and do you see that as something that the students might actually be interested in?
Well, first I want to thank GHI and Dr. Badr and Dr. Abu Sitta for having this setup and having us all being here and addressing this issue. And I think this is a very important issue, especially that we all deal with the aftermath. Like our colleague said in the morning, it's what you do on the ground that matters. However, you need to educate people on what to do. Otherwise, the hit and miss are going to be much larger than we can accommodate. Now, I believe, and as you mentioned, Kamal, the education to conflict medicine has to be kind of gradually incorporated at different levels of education, whether from undergrad to residency to fellowship. But should we create a program that it's structured to have conflict medicine education and have certification in that, I think it will be very attractive in areas where are boiling areas like our areas in the world. Hopefully things will quiet down soon. That's what we all hope for. And then they may be out of business. So the problem is, I think, if we create a program that is going to be multidimensional and having lots of recruits, I think with time we may run into redundancy into this field, because the need for these expertise are going to be episodic. So the way personally I see it, it's a very important program, but had to be coupled with more training, with a different dimension of existence. Maybe related to supporting issues such as, the well-being, the burnout, how to manage the conflict medicine and the people involved in conflict medicine, and how to educate about maybe gradual involvement. But it has to be very well engineered to attract people and to have a sustainability, especially when we are out of conflict times.
So you don't think that a residency in conflict medicine is something out of the question? You mean you feel that that's something that can be formalized into a structure that could be eventually accredited?
Truly, true. I think we can adapt it in a way that have a sustainability system, and that will be attractive, I think, to more people, and then that can be sustained, yes.
Yeah, see, that's one of the things, Shadi, that I had asked, in that if you want to make this a global effort, then perhaps naming it disaster or including disaster medicine rather than just conflict would make it something that we could, because the consequences on human suffering and mental and physical and displacement and by a major earthquake or a fire or are very similar, although I'm sure there are differences from those in a war. But if we're going to make this into a program that becomes accredited by international agencies, I think expanding it beyond conflict might be something.
I think crisis management in general would be more...
Okay. Let me turn to Sola. And let me ask you, Sola, and you know, you are a dean of a relatively young medical school, and you have been a part of the team when we created a dynamic new curriculum that incorporated skills and competencies that were not present in previous ones, or that were not, at least in Lebanon, commonly done. Do you see some new competencies that we might need to incorporate, and how do you see those being incorporated into the medical student curriculum as we now have it?
First, good morning, and thank you very much for having me among this great panel and great audience as well. Unfortunately, I couldn't attend the morning session, which, as you said, Kamal, set the tone for the following discussions. But regarding the integration of the possible integration of conflict medicine in undergraduate medical education, in my opinion, it could serve as priming of the mindset. Because, as you know, readiness is one of the core competencies now in conflict medicine. So people need to be aware, ready, prepared, and so on. So priming the mind serves like a pre-internship, and there are models whereby such pre-internship or virtual internships happened and existed. I, of course, see that there is a role for new competencies. It's the same like what's happening with AI and digital health competencies and the new frameworks. And I see this happening also outside of the traditional frameworks like the AAMC or ACGME frameworks. There are new competencies and competency domains as well emerging, rather than fitting into the 6 or 8 domains of competencies. So definitely I see this happening. I see this enriching, and I see this as priming of the mindset in preparation, which no one of us would like to see these happening, but in preparation for any possible disaster. Now, if like you were saying, there are generic and basic competencies that would be integrated, but there are as well specialty-specific competencies that I see being integrated in residency programs, but definitely in undergrad.
Can you be a bit more specific or granular in terms of this priming the mind?
Yes.
So how specifically would you do that?
In terms of delivery, it depends on what competencies we foresee as generic and a student upon graduation need to master. Personally, I see them more as tasks or activities, like to have them as EPAs, including or integrating several competencies. And examples would include having online modules, because when we speak about priming, it's mostly starting with the knowledge, sharing online modules, training videos, and so on. And following this, what we call like the pre-internship models, using simulation models, simulated patients, virtual patients, leveraging AI and the new technology to deliver hopefully low-cost priming through all of these modalities, I think they help a lot in at least creating this mindset toward conflict medicine, role modeling, involving of the students, and mutual role modeling. I think these could be some interesting modalities to be integrated.
Yeah, so you see this then being introduced at the medical school level in terms more of cognitive concepts that are introduced into medical students' minds, which they don't think about now. Let me turn to you, Sami, and see whether you can think of, or you can. You are the dean of a medical school that's not that new, but you are new to it.
I am new.
So have you thought about potentially creating some ideas in this vein that might change the way you do things at Balamand?
Well, to start, I would like to thank the organizers for this meeting that, in my opinion, is most relevant for us in this region. Dr. Abu Sitta described how this started from the Nakba until now, and it's a continuous conflict zone, wars that are probably going to be never ending, and we are here to stay. And we are educating our physicians and doctors and paramedical elements in the system of education about how to deal with this continuous problem we are facing in our region. So I, as a new dean, and I do not claim that I have that much knowledge on conflict medicine, I thank you for this opportunity because I had to read and try to educate myself about it. And I jotted some points that I hear that are relevant to your question, and I have come up with certain answers to what you ask about how to integrate conflict medicine in the curriculum. I think here we have the issue of integrating it in an existing curriculum. We have certain advantages. The curriculum is there, and so the advantage is that the curriculum can be modified in a way to make it more efficient and incorporate conflict medicine into courses like the courses we give, public health courses, emergency medicine courses. And we should not also forget ethical discussions that we carry on in the existing curriculum. So incorporating this conflict medicine would be interesting. Students can see how conflict medicine intersects with broader concepts such as epidemiology, trauma, emergency medicine, and so on. So I think this is easy. However, this comes with certain disadvantages also, and the disadvantages I listed here is the scope of the conflict medicine may be constrained due to time. We cannot expand our curriculum to include everything that we would desire to include, and the way that one would imagine, it will be fragmented. It won't be like what you suggested, a course. It will be fragmented in the curriculum. So that's one disadvantage, and I'm sure if we do not give it its significant importance and weight, many topics will be marginalized and will be missed in that. So, and we should also think that what if we create a course like what you suggested, a dedicated course, that has certain advantages a standalone course will allow us to go into depth into exploring all aspects of conflict medicine. We may want to have hands-on experience and training. That would be a problem, I think. It's not easy to send our trainees to conflict zone areas, but maybe with the help of simulation and or sometimes with allowing them for electives or so to go and train in certain regions where conflicts are taking place, that would be an option also to consider. So this is one possibility to create a whole course, but it has some disadvantages. I said that disadvantages would be it will be costly. You have to have dedicated faculty members, experienced faculty members, and also resources are scarce and limited to do so. However, with the help of the WHO or the Médecins Sans Frontières or the Red Cross and so on, one can incorporate hands-on or field experience for our students. So I have ideas, but I don't know how easy to implement them, but I think we should start somewhere. And I mean, these are
Thank you very much for really providing at least some context in terms of these two models. I think you're absolutely correct in your analysis. Like if we take another, let's say, theme that we want to incorporate into the curriculum, I take the example of evidence-based medicine that we sprinkle into all the courses. So in the pulmonary course, there's evidence-based medicine, but none of the students really comes out to being a real expert in evidence-based medicine. All right. The other idea is to have a course that all the students have to take. Before I go to Dr. Tamim, he was going to look at a totally new paradigm of conflict in medical education having to do with the GHI initiative. Let me explore again at the medical students level whether or not, number one, we want to teach this to everybody, or whether we should allow students, even in Gaza, where there is a big need, to also have the chance to choose a track that is focused on research. And another group of students is a track focused on social medicine, conflict medicine, and we've already started those tracks here in the scholarly concentration track. And then you have, at the end of it, potentially a continuation into a graduate medical education. And you produce a cadre of people who are ready to be deployed and well-trained all through their journey. Sola, do you think that consider such idea for tracks at LAU?
Yes, absolutely. Thank you for raising this point. First, I want to mention about improving on curricula. We frequently think that this means adding to curricula. But in fact, we need to think a little bit differently, because improving on curricula would imply sometimes subtracting from curricula. So the content that we put into curricula has to be revisited all in all, because we're dealing with really different constructs, different world, and a lot of emerging fields that we need to account for, rather than expanding or adding to curricula, maybe subtracting something and being innovative in the way we deliver it. Now, I totally agree with what Sami mentioned and with what you're saying, Kamal, in that if we keep these competencies as learning objectives embedded within the general framework, frequently people do not grasp the fact that they really took a specific course. I see the value in having not only a thread, or maybe have it like clearly stated that this is conflict medicine, that would include modules or specific teaching entities that give the feeling and that we are really taking a topic about conflict medicine and not just implicitly having it put inside the learning objectives within modules and so on. Concentration tracks, that's absolutely a very interesting path. to consider, specifically that now we're the evolving curricula, we're including electives within each year of the medical curriculum, not only in Med 4. So having it as a concentration track, this is absolutely a very plausible way, in my opinion.
Thank you.
May I add, Kamal, Bas, if we can have it embedded in the curriculum at a horizontal level in the preclinical years, then continue with it in a vertical way to postgraduate training.
That's what we're suggesting.
That would
We'll
really
come back
help
to that and talk more about the graduate training, but I want to turn to Dr. Tamim. Dr. Tamim, you have, you can use that one there. You come with a paradigm that's totally outside the box in a way in how to inculcate the teaching of conflict medicine, and that's thanks to your collaboration with the GHI. We're very anxious to hear about this and overall also as to what you are doing in Adan in this respect.
Okay, thank you very much. Really, I'm very happy today to be in AUB and especially in GIH. In Global Health Institute for the third time here. I really am very happy. And by the way, I am going to thank the rector of the university, Dr. Shadi, the one who gave us the map route, how to look for the conflict meds. During the year 2022 and 23, I'm going to revise our curriculum in the College of Medicine for accreditation. And by the way, I find a lot of topics related to conflict medicine was already integrating in certain subjects, including epidemiology, including behavioral science, including surgery, trauma, orthopedic, pediatric, psychiatric, all there are. By the way, our curriculum was founded in 1975 by Cuban professors, University of Havana at that time during BDRY, Yemen Democratic at that time. And this has been revisioning more than 5 or 10 times. 5 to 10 times have been revisioning. But really now we are revising it again in order to adequate integrating all these things regarding the conflict medicine. Our work with the Global Health Institute at University of Beirut, really we admitted around 23 student internship and newly graduated, and they are run for I think 6 months. All of them they get a certificate, and really these people after they finish they have a lot of impact. Most of them they go to have specialization in Arab board and Yemeni board and master degree. All of them they take some related to conflict medicine. Either we have a training, sometimes a workshop for the new graduated, how to select your specialty. Most of them have been affected, and this course has an impact and direct them toward the conflict medicine, especially vascular surgery. Have to imagine in a region like Eden, now we are going to graduate more than 12 as vascular surgery. Before 10 years, sometimes we are going to amputate. Really, there is no one. This is one thing, make these students go for some hot areas. At that time, nobody care about it. Emergency medicine, war surgery, they go for orthopedic. Before, I think for 10 years, really, we are going to interfere in a lot of injuries regarding trauma in the lower limb. Nowadays, everybody has been changed his mind to do something more or less, you say that is conservative or external fixator for the fracture rather than to go for surgery and lose the limb. So I think that really we are appreciated this relation. And by the way, for Dr. Saleh, that the student in the new graduation, they ask me, when you are going to provide us with another session of telemedicine with the University, American University of Beirut. Really, I am really appreciated this work with them. And by the way, the dean or director of the University of Aden, he was with me in last May at the College of Public Health. At that time, now we are thinking that we want to improve what it is already integrated in the subjects. We want to improve it by a knowledge, scientific, academic, to be at least this student, once he is finished, he is aware about that. The other thing, we think to have something related purely for conflict medicine as postgraduate, either to diploma or master degree. Really, we need, in our country, we need this branch of medicine to be emphasized, because we are area of conflict. Since I born, we are conflict up to now, 60 years, we are in conflict always. So we want this one to be highlighted, either master degree or diploma at least. And we have a lot of facilities, including the patient is there. The community is needing to be helped by some specialized in such situation, as well as the knowledge can be reached by their cooperation with the University Global Health Institute, for example, by telemedicine, by using internet, by using simulation. By the way, also we have a good skill center has been provided to us from WHO. We use it for all, from first year up to the postgraduate. That's the thing.
Thank you very much. This was really an amazing exposition of this. Shadi, maybe we can talk a little bit about this course, because it reminding me of SHARP, which is a course that's also given for graduate students who are interested in clinical research, and they use it as a springboard to become clinical researchers. So could this be the best vehicle to create cadres of people in conflict medicine, is that this course becomes, I mean, the experience of Adan seems to be very positive. And this is only open for graduates, for medical graduates, or also for nurses or other. Can you tell us a little bit about it?
So the idea of conflict medicine is, and you know, whereas historically it used to be just war surgery, the idea of conflict medicine is that conflict, especially prolonged and intense conflict, shapes what is a social science, which is medicine. Just like the Industrial Revolution shaped medicine, persistent conflict shapes medicine. And it shapes every aspect of the provision of healthcare, medical, nursing, rehabilitation, and it shapes every specialty within medicine. In Syria, over the period of the war, in Gaza, in the war, shorter war in Lebanon, the provision of dialysis services had to be changed. The provision of cancer services had to be changed. The provision of the understanding of infectious diseases and their relationship with the injury had to be changed. And so this course that we created provided a core, and then for those who are interested in a surgical route, there was a second course. Those who are interested in infectious diseases provided a second course. And within nursing, there is also a course for people to apply. And what we found, not just in Aden, but also with the Islamic University in Gaza and with some of the medical students in Lebanon, is it completely changed when they did it either in the final years or immediately upon graduation. It was a primer for an interest in this disease load, but also completely changed the way they viewed that disease load, and they felt much more confident and less isolated when dealing with these injuries.
Excellent. Thank you. So that's a wonderful thing to
one observation regarding the management of trauma, especially in our country, before 2020, what happened? We have only a little ladies in surgery. Nowadays, we have a lot of them are in general surgery, even in orthopedic and neurosurgery. They are working. You know, this area is very hard area in the work, but they go because they got an information. Global information sometimes directed the new doctors for hard specialization.
Thank you. You brought up the whole issue of technology, and obviously that's a very we cannot talk about anything now without talking about how the new age of artificial intelligence, as well as all the technological advances in telemedicine and how to put these to use in providing top quality consultation care, otherwise to areas that are in conflict. You have had a lot of experience with that previously and we'd like to know whether you see that also as part of the new training. I was mentioning that 5 years ago we had a meeting here at AUB that addressed what are the competencies of the physician in the 21st century, if you remember. And we had a lot of people from technology, including your brother from Google, and we had a lot of people from surgery. We had a large group from the United Kingdom, including Sir Richard Kerr, who was the president of the Royal College, or was leading the Commission on the Future of Surgery for the Queen, and Rita Sharon from New York, who created the narrative medicine program, and we had a lot of input from humanities, and our aim was to see how we could redefine the medical curriculum to accommodate the two competencies, one in humanism and the other in technology and data science. And as a result of that meeting, and this is a completely new angle now on this, we changed the pre-medical curriculum at AUB, not the medical curriculum, because as you said, Hassan, it's really there's a whole mental setup that needs to be created. And so on the humanities side, we reintroduced a lot of the courses that had been made as elective in psychology and sociology and history and literature, etc., or one of those humanities. And we introduced an obligatory course in computer programming as part of the training of any pre-medical that there is no physician who cannot be computer savvy in the future. So where do you see that coming in? Salah, would you like to pontificate on that issue? And technology, do you see it happening already in your practice?
I think we're bound to see it happening, and it's going to come whether we like it or not. So it's better to embrace it and move on. And as we mentioned before, just to go back for a minute on that issue, yes, I think it's important to have some small building blocks of conflict medicine at different levels of education, and as we grow and mature out. And then it starts the diversification more into the specialties. The emergency medicine trainee will have more interest in specific cases compared to the nephrologist, to the pulmonologist, to the critical care, to the endocrinologist, and vice versa in all aspects. But at the same time, there should be a parallel maybe course, like in what you call the added skills value, or like the French sometimes call it DU. So it's like a formal training, like 6 months or whatever, maybe not a full residency at this stage, and just to build the capacity for people to become trainers after all, and to become the people who will be building a program in the future. And now simulation is a big thing for technology that has to come in the picture, diagnostics at the same time. But in the same way, I look at it personally from a different perspective. when we deal with conflict medicine, especially in our area of the world, and I'm sure Ghassan experienced it big time, is we deal with very limited resources. So we need to train our people to practice with limited resources rather than with super fluent resources, because that's the nature of the crisis we live through, whether it's a natural disaster or military crisis as we happen. However, the training is going to be essential since we don't have much hands-on. It's not going to be like you're going to take them to conflict zone and train them. Technology has to have a big role into the simulation, into building up the capacity before we reach, the imminent implementation of the skills.
But if we back up a little bit, I mean, it's okay, 6-month course or a course like this and so forth, but does that equip you to deal with multi-trauma type patients, as was mentioned before? How do we recreate the surgeon who can deal with all these types of interventions and in a competent way? Shouldn't there be actually a residency or a fellowship training that is similar to general medicine, where people see everything, or even family medicine, where they also see obstetrics and pediatrics? Should there be a kind of a regression, if you want, but I wouldn't call it a regression, in surgical training, where you train surgeons on these multiple skills? Is that something that do you see that happening?
I think surgeons nowadays, they do not, they're into technology, and they have no experience about open wounds or classical old-fashioned surgeries. So obviously it's good to reintroduce them, and if they do not have the opportunity to encounter cases, the open wound operation, probably via simulation or via e-learning, via other tools, learning modules that one can introduce in the curriculum for them to be really acquainted with this old-fashioned and needed approach in surgical.
This is a good endocrinologist view into surgical training, but I think it's hard to train people on surgical techniques virtually, right?
I mean, nowadays I can share with you my short experience with our students. When they finish, they want to go into plastic surgery. They want, most of them would like to do the aesthetic part, the cosmetic part, and they're not so happy or excited about the reconstructive part. And then this applies to most of the surgical specialties. So, and unfortunately, the load of patient is geared in that direction, aesthetics and cosmetics. Yeah. So, I mean, we have to find probably training sites whereby they can go back and acquire the programs and acquire skills. Ghassan.
So, and Tom and Tim would back me up on this. The issue is the mismanagement of the war-wounded patient that happens at the beginning of each conflict is on the basic principles rather than the complex skill sets. It's on the fundamental management that where the mistakes are done. And as I said, in the age of antimicrobial resistance, our patients are going into a spiral of repeated, prolonged care rather than a shorter route if properly managed. The other thing to talk about with regards to technology, not only in education, but the democratization of technology, the fact that your ultrasound machine now is just a probe that you can see on your phone. For me, one of the most impactful programs that I had seen, ICRC did in Gaza, where they taught all of the surgical residents and all of the emergency medicine doctors and residents at Shifa Hospital how to do the quick ultrasound examination of the abdomen. And you could see, even in the most difficult of mass casualty, that multiple people had the ability, as part of the workup and the investigation of the patient, were doing this kind of work, which almost kind of was unimaginable 5 years ago. But it shows that technology is also heading in a direction of becoming much more accessible. So people are moving from 3G to 4G phones, which means that there's much more in terms of virtual augmented support that they can have. And technology moved in my lifetime where the pulse oximeter went from costing thousands to costing $15, and now ultrasounds are available for use and will replace the stethoscope at some stage in undergraduate education. So we have both parallel things happening. But the essence of conflict medicine lies in recognizing the endemic nature, and therefore the need for us to recognize the endemic nature of this ill health.
Yeah, Dr.
Tamam.
Tamim, Sola, you have something?
Yes, it's about
Just a minute.
exactly what was mentioned about the generic skills. This brings me back to my first comment. In fact, in conflict medicine, it's not necessarily about the very advanced surgical skills, but there are a lot of competencies that depend on a basic readiness level. And as an example, the triage that happens, the very first wound management, the communication in crisis situations, decision-making under pressure, cross-cultural communication. So there are a lot of competencies that really, I think, we need to start training the students before they become residents. And considering the formation of just teams that are involved directly in this type of conflict, we know that the resources are really stretched out, and we need, in these times of conflict, you need to deploy many other healthcare providers. So this makes me think of the BLS, ACLS. So as every physician now has the basic life support that is revisited every 2 years, and some others who are directly involved will get ACLS, and so on and so forth. So definitely we need to maintain our skills with multi-leveling of who should know what. And then depending on the specialty, anesthesiologists will be doing something, and other specialties would learn something else and work in teams. And the final word about the type of conflict that we're encountering, which is, it has become hybrid. So we're not dealing with the regular conventional conflict military forces, but there are lots of unconventional methods that are happening, which will make us also team up with other types of specialties. So it's a multidisciplinary. There are cyber attacks that are being involved, disinformation, and all of these really are very important in conflict medicine. So it is complex. That's why the idea of residency, in my opinion, at this level, I see it a little bit premature until we understand whether it has to go with the disability or and how to sustain it, and where would the residents train. So yes, having teams ready, it's a yes, but there are generic skills that are requested, I think, from everyone else.
Thank you. We'll take a final comment from Dr. Tamim and then open the floor for questions.
Yes, I want to
Please,
comment. Yes,
you're the only surgeon in the
thank
group.
you. No. They say that really the problem in the limited resources countries, and those who unlimited resources, they have no crisis, never crisis. I think a crisis, if we look for the map of the Arab countries, maybe Yemen in the south, and the other country in Sham, for example, and Iraq in the north. And between us, there is no any conflict, I think. So I don't see even, they are not asking for those working in trauma and disasters in reality. Maybe disaster, trauma of road traffic accident and something, not of war problem. About the integration at multiple level, as I said before, it should be organized, and at any level we have to improve the syllabus for this integration. What should be done for practical things. For example, yes, Dr. Qassani speak about ATLS والفاست إلى آخره. هذه كلها okay, can be done. Now we are establishing in our college no exit from baccalaureate unless he do everything requirement. All workshop for trauma, in medicine, ECE, they have to be certified. And then we give him the final certificate. For the work interventionally in surgery, especially in trauma patient, we know that those classical surgeons now become very limited. And we need to at least to maintain those who has a good experience to deal with trauma. Trauma is not just to open the abdomen and sometimes you do nothing in the abdomen. This is what been happening. This is, I feel it in 2015 when the last crisis, which is up to now in Yemen, a lot of mortality during surgery. All the hospital, they are working for all types of trauma, but the mortality is very high because the experienced one is not present. There is not aware about how to deal with this mass casualty, and most of them are very critical. They need intervention. Later on, the Red Cross as well as MSF interfere, and they are improving. So we need to build the conflict medicine as something postgraduate. Take useful things from those people still alive, still they are able to work in order to teach the new generation of the doctors. Thank you very much.
Thank you.
And I'm just trying to synthesize all of the information from the two sessions to be practical in terms of approach. So it seems like a practical approach may be to divide the conflict medicine integration into two components. The first component is a required component maybe at the pre-med undergrad level where we sensitize medical students about conflict medicine, not including only surgery because it includes mental health, it includes trauma care, it includes community, whatever. So this is the sensitization. Everybody should take it. But then at the level of residency, whatever we want to call it, then it becomes a choice where the individual can choose if they go, instead of going to pediatrics, they go to whatever, maybe not call it conflict medicine, but maybe call it disaster medicine or whatever. And then there is a residency program or an add-on program, Hassan will tell us more about his thinking, that may be 6 months, that has to be also heavy on simulation and technology. And perhaps a rotation with ICRC, with MSF, with a humanitarian that's actually practicing in Yemen in the ground to actually see that. So in the residency, there's a didactic part, or whatever you want to call it. There's a simulation using technology part, and there's an on-the-ground component part. هذا thinking. 2 components, undergrad for everyone, sensitization, and then a choice in a residency program or whatever. Shu Kamal, does it make sense?
It makes a lot of sense. It's very well put.
Hello, I'm Dr. Hassan Nahouli, practicing orthopedic surgeon. My background will be of help to taking some decisions. So I am a graduate of this institution, undergraduate medical school and orthopedic residency. And I was practicing orthopedic surgery during this war in the South. So I treated around 300 patients along with a lot of colleagues. And I saw a lot of what the first panel talked about, mistakes in the principles. So we had a lot of patients who were sutured in the EMS. And then when we were removing these sutures, the patient would ask, why? I have my wound closed. And you had to explain to the patient and to the EMS, whether they were nurses or volunteers, that this would actually cause harm. And this goes against our oath that we should not cause harm to these patients. Another thing is, in specialties, like orthopedic surgeons would be thinking, how should I fix this fracture and disregard the open wound and leave it for later, and not have a plan, and that this wound should be closed in 2 weeks' time, and now we have to think about the debridement. and primary fixation, all these principles mixed up. So we have different levels of gaps. So to start with, I agree with Dr. Saleh that the basic principles should be taught for everybody. So all the medical school, nursing schools should have a teaching to the basic principles, and this could be called as a conflict disaster medicine exposure course. And it's not much. It's a couple of lectures, some videos, maybe a few simulations, and I don't think this is very difficult to incorporate into the programs that we have. The second thing, and the second part is each subspecialty needs a certain type of training for conflict medicine. So infectious diseases, doctors should have the experience to deal with these open wounds of patients. And then the orthopedic surgeon should be able to apply the different kinds of fixators for these patients. So in my training, I was trained to apply the very fancy fixator, which cost $15,000, and then we rarely applied the Hoffman fixator. So what helped me was my interest in conflict medicine and my personal effort, where I went to different courses, and thanks for GHI, in 2018 they got the David Knott course, for example, as example of course where we were exposed to how to deal with war injuries. So I think each subspecialty, as a conflict medicine program, can incorporate few things to each subspecialty. As we heard now, every open wound, open fracture and war-related injury needs an orthoplastic approach. So our programs at AUB, having to work very closely with Dr. Ghassan and all the plastic surgery, gave me an edge, an advantage. And I think that should be incorporated in all training residencies. So I cannot tell you how many wounds I've dealt with local flaps, skin grafts, and these are skills of plastic surgeons. But in war settings, a lot of times we do not have plastic surgeons, so we should be trained on these areas. Same thing for vascular surgeons, same thing for emergency medicine doctors. So I think in terms of how to build, I think we should add into each subspecialty a certain set of skills that they should learn and call this a conflict medicine addition to these fellowship, to these residencies. Now the final thought is if we should have something called a disaster medicine fellowship. This is, I believe this is the most difficult and challenging part because we don't always have disaster happening. So this person who's in training, postgraduate, could be of, or have the necessary exposure in order to have that skills. But I think incorporating the skills needed into the trainings, postgraduates that we have would be ideal. Thank you.
If I may, Kamal, I totally agree with this approach.
Ma'aleh,
Dr. Saleh.
Dr.
Saleh, I mean, to have a dedicated subspecialty, it's going to be difficult. So this approach, in my opinion, is more practical and easier to implement.
Thank you. Yes.
Yes. Hi, I'm Dr. Habballah. I'm the chair of surgery, and just want to comment on the remarks made by our graduate, Dr. Hassan. We already have a lot of courses that are available that can be incorporated very easily into any program. We have courses through the American College of Surgeons, the ATLS course. We have the Stop the Bleed course. All of these courses are available and can be easily integrated within any global health and conflict medicine program, because it gives you and teaches you the very, very basics of managing acute injuries and acute wounds, and how to resuscitate, how to control the bleed, and how to do it without causing additional injuries. So I applaud your efforts, and I think we can easily integrate some of the existing courses with what is needed. Thank you.
Thank you, Jamal. This is a great resource to know about. Yes, sir.
Hi, I'm Andy Ferguson. I'm a family doctor and public health specialist. Been working in international health development for nearly 30 years now. Just following on from one or two comments about those institutions running residency programs, establishing reciprocal arrangements with certain NGOs who are providing clinical care in conflict zones. I think this is a great opportunity. You know, senior residents in a variety of specialties then, not just the surgical specialties, but family medicine, public health, all of these have an opportunity to gain field experience, but working alongside experienced clinicians, but within a structure that can provide the necessary logistic support, security support. But not only that, your institutions then gain access to visiting lecturers for your undergraduate and postgraduate programs, because the danger is that that training is being provided by people who don't necessarily have the full experience needed, whereas if you have those relationships, you gain immediate access to that pool.
My name is Naya, and I am a social worker. In high-stress conflict settings, healthcare providers often face significant emotional and physical strain, so which can lead to burnout and can affect the quality of the care they are giving. Given the importance of addressing caregivers' well-being, should conflict medicine curricula include trainings in providing care to caregivers like stress management or mental health support or building residence among the health caregivers? Thank you.
Salah, I mean, I think that's an extremely important part of this. That as with all health professionals, building on Shadi's synthesis, and if we want to come up with something concrete out of this meeting, I think perhaps what we need to do in order for all these integrations at the various levels and the various modalities to make sense and proceed in a seamless way is to have one body put together a document proposal that would put all these things in and that a lot of the people here be on that, not just an AUB, but including the regional partners or partners at other universities, LAU, Balaman, everybody, and come together on something under the auspices of JHI, since you have organized this meeting.
Yeah. Good morning or good afternoon now. Laetitia Numouche here from the ICRC, so I'm the health coordinator here in Beirut with the ICRC team here. Just wanted there were some other questions before I wanted to intervene to say I think the win-win collaboration you just mentioned is something that is sought by the academics as well as the humanitarian actors. So we are in an era now where we are trying I'm talking about MSF and ICRC specifically, to develop those type of collaboration. So we already developed projects to collaborate, to have this theoretical component as well as embedded in a more exposure component of the thematics. So ICRC, for instance, we developed what we call war surgery seminars, which embed in academics. So in Beirut here, we had like 5 years history of collaboration with an academic. We are now thinking it's exactly the right moment to resume this type of collaboration. And we have developed this similar project that is promising in East Congo, in French-speaking country. So the idea now is to have like more a regional Arabic-speaking region implementation. Thank you.
That's excellent. Thank you very much. I think the GHR will be happy to make contact with you on that and include the ICRS and MSF in the comprehensive program we're trying to put together as the areas where the field experience of these trainees could be provided, and it doesn't have to be in the region. It could be anywhere around the world if somebody pays for it. Okay, one more comment, and then we'll...
just a comment about the gap in the skills gap for surgeons in general competency is not just in conflict medicine. It's been recognized in the civilian setting elsewhere, in highly developed settings, and there's a move to establish the emergency competent general surgeon again, to row back and to try to incorporate general surgery back to where it was. This is in our College of Surgeons in England, and I suspect it's elsewhere. It's being battered around, but it's difficult because most of the patients want to, wherever they are, want to be operated on by the specialist, the top specialist in whatever skill. But actually, there's a real need, there's a gap in this competency, and that skill mix could be developed into, certainly for general surgery, into conflict medicine as well.
Yeah, so this is Fatima Mshek. I'm a med-ed faculty member at AEB. So based on those two panelist sessions, I'm trying to synthesize my ideas. And internationally, outcomes-based education has become the standard, and different countries, they have developed their own conceptual frameworks. We have in South Africa, America, UK, and many of those frameworks, they share a lot of similarities. They went beyond defining the physician within the scope of patient care and medical knowledge and expanded those definitions to tackle communication skills, professionalism, system-based practice, and PBLI. And this takes us back to the definition of preparedness. And the way physicians are evaluated on those domains is based on the preparedness on those domains and their competencies. And the definition of preparedness has taken a lot of inspection recently, and it entails self-confidence, adaptability, problem-solving skills, decision-making skills. And we have a lot of competencies that address that they are already there and well-defined. They address leadership in crisis scenarios. They address being able to find alternative medications, solutions for patients' treatment. So competencies are context-specific. We have already a long list. And when we say context-specific, then the sky is our limit. We can go in complexity in each competency we have. We can expect our trainees to lead in different contexts and train them there. So why enlarge, and sorry, I'm not trying to burst the bubble, but why try to enlarge this tree of competencies? We already have a long list. And why try to reduce them into specific skills rather than embedding them in every competency? Just like when we talk about patient-centered care, it's embedded in every competency we have. And similarly for conflict medicine or any other emerging technology, we can't keep on updating those competencies every now and then, but rather redefining the context and thinking about our curriculum, how to redesign it to meet the different contexts and the emerging ones. So this is my question. Do we really need to expand the competencies list or think about our curricular gaps and try to fix them and embed those new emerging skills that are needed in every curriculum? It's very impractical to have diversified or dissected curricula for each resident. I know it's nice in theory, but in real life practice, can we really implement it? I can't see it coming in practical terms. Thank you.
Thank you. I don't think anybody is suggesting that degree of differentiation in curricula, but I think the question of whether we're going to fix our existing, embed things in our current competencies or create new competencies is more or less a matter of semantics. I mean, the thing is we need to teach this stuff at some point, and but your points are well taken, and they'll be the subject of the next meeting. Right, but I think I'm limited by time. I'm told I should finish by 12:30, so I think there's one last point here. Okay.
Yes, so my question is to Dr. Zainuddin and Dr. Sola. We know that because we are here to explore practical approaches to actually integrating conflict medicine into medical education. And we all know that most of medical schools and residency programs, they have to, abide by certain accreditation systems, ACGM, EI, and other accreditations. So practically, is it practical that we integrate conflict medicine into existing programs, and will this fulfill the requirements of the accreditations, or is it a better approach that we complement the existing programs with extra programs like the certificate in conflict medicine or other tailored programs?
Well, I believe we can do it at two levels. The accreditation bodies, most of them dictate to us what is the minimum required for accreditation and what is the maximum allowed, but there is always a flexibility in between. So we can always integrate courses or modules for different topics that we think they make a value of whatever kind. In this condition, we're talking about, of course, conflict medicine. So I think integrating it into the curriculum makes more sense at one level, because adding more time or maybe a burden rather than, a service for most people. However, when people are more entitled in terms of being more interested to follow through, they can be offered a separate program as we just discussed. So this could be like what people would choose to continue on. But I think the building block that we need to make can be integrated in programs, but there's always a flexibility to do so. Of course, if you have a 3 years program in internal medicine, you would not add a year, but you can easily add a couple of months for conflict medicine, for example.
Just a quick word, I agree with what Salah mentioned, and what you are suggesting is also a very nice approach, and Kamal had alluded to maybe have like a certificate which can run in parallel, or an elective, or a concentration, so both can be options.
Thank you. Thank you, everyone.
Thank you.